All right, we'll get started. I'll use the handheld mic. It was either that or I needed a stool to reach over my computer. Good afternoon, everybody. Thank you very much for coming to the last session. It gives me great honor and pleasure to be part of this last session. I think probably, hopefully, one of the most exciting sessions as we move on and close our meeting to talk a little bit about what's on the horizon. My name's Mielniczuk. I'm a cardiologist. I'm the director of the PH Clinic at the Ottawa Heart Institute in Ottawa, and I'm joined by three friends and colleagues, I think many of whom you know, but I will let them introduce themselves.
Hi, John Swiston. I'm the medical director of the Pulmonary Hypertension Clinic here in Vancouver.
I'm Duncan Stewart. So I'm a cardiologist. I work at the clinic in Ottawa, the Ottawa Heart Institute, and my passion is doing research and trying to develop new ways of treating pulmonary hypertension.
Did Duncan bring a cheering section with him? I have a little cheering section too, Duncan. We'll see. I'm Sanjay Mehta, lung specialist and PH doc from London, and most importantly, chair of your PHA Canada.
Your section's bigger than mine.
That's excellent. All right. So we're going to get started, and we want this to be as fun and interactive as possible. There is some material that we want to cover, but I'm really going to look to my colleagues over here and put them on the hot seat, if you will. That's why they have those nice, comfortable chairs to answer my questions and, of course, your questions more importantly. So I've been in this field for over 10 years now, and it is, I think, one of the most exciting fields to be in pulmonary hypertension in cardiology, because the advancement over the last 10 years has been enormous. As most of you know, or many of you know, 10 and 15 years ago, there was 1, 2, 3 maybe options for our patients. We now have a landscape in Canada where we have 10 approved therapies and more on the horizon. There are still some differences across provinces, and we're working hard to get all patients access to all medications, and that's a lot of what you folks have been doing and working with us, and we're grateful. Over the last year in Ontario, we've seen approval of Uptravi, and we're very happy and grateful about that, but we still have some work to go. There are still some therapies that some of our patients in some provinces don't have easy access to. You may have seen this picture before. This is a picture that talks about the 3 pathways that cause the disease of pulmonary arterial hypertension. And I'm not going to go into great detail, and there's no test or anything at the end of it, but it's important to know that the therapies that we're using right now are working for the most part on these 3 pathways. Patients with pulmonary arterial hypertension have too much of something called endothelin. Endothelin is a very potent vasoconstrictor. It constricts the blood vessels in the lungs, but it also thickens the blood vessels. It makes the cells in the blood vessels abnormal. And so blocking that pathway is a really important strategy. Patients with pulmonary hypertension, for a lot of reasons, don't have enough nitric oxide. And the nitric oxide they have, they can't use it very well. And nitric oxide helps to dilate the blood vessels. And that's very important. And so we use medications that will help us to improve the way we use nitric oxide in our body. And patients with pulmonary hypertension have abnormalities in prostacyclin. Prostacyclin also helps to dilate the blood vessels. And so some of you are on drugs that are like prostacyclin or help to stimulate the response of prostacyclin to dilate the blood vessels. And so some of these medicines may be familiar to you, and over the last 3-4 years, in fact, new drugs along those same pathways have appeared. So on that endothelin pathway, we have new drugs like macitentan or Opsumit. On the nitric oxide pathway, some of you may be familiar with drugs such as riociguat or Adempas. And on the prostanoid pathway, some of you may be familiar with the medication called Uptravi or Selexipag, an oral medication that helps to do the job and stimulate the response of prostacyclin. And so I'm going to stop there first, and I'm going to ask my panel to comment a little bit about this. We have 3 pathways for pulmonary arterial hypertension, new drugs that work on the same pathways. And maybe I'll start with Dr. Swiston and ask him what his thoughts are about these new drugs and how he uses them in his treatment for his patients.
Hi, thank you. Talking about the new drugs in pulmonary hypertension, as we know, the landscape is something that's something that is constantly changing, and it's partially new medications. It's partially how we incorporate that into the overall the patient care, and changing also sometimes the indication of the medications or when we consider introducing them. And so many times, one of the greatest advantages is that we now have multiple medications in each sort of family, and that allows us to have some choice. In the Q&A session, there was some questions about side effects and complications from certain medications. And one of the advantages of having more than one medication to choose from in each pathway is that we can tailor the medications to patients, or try to avoid certain ones in some situations if we need to, and try to reduce the potential for complications with different medications. And the other part is, again, having more choices with medications is being able to constantly reassess the medications the patients are on and consider whether we need to switch medications, add medications, or change combinations of medications that we have patients on.
Dr. Swiston, do you think these new drugs that work on the same pathways are better than the drugs we used to have that work on the same pathways?
So we don't know for sure. There have not been any trials that directly compare the medications one against another. And so we don't know that one is necessarily better than the next, or that one family, in fact, is necessarily, for some of these medications, is better than others. And there are some things that we may think that in certain individuals or certain populations, we may feel that one particular drug is better than another, or in a certain clinical circumstance. But from a blanket statement, there's not one that we necessarily think is different than the others. The obvious difference being the IV and the parenteral medications compared to the oral medications.
So we believe these pathways are really important in helping to treat and combat this disease. But obviously these pathways aren't the only pathways that are involved in the disease progression, because if they were, then we would love to, nothing more than to stand in front of you today and say we have a cure for this disease. And so we need more work. More work is being done, and I'm proud to say that Canada, I think, is actually a world leader in some of the work and research that's being done in helping us to find new pathways to target this disease. And there's really exciting things coming down the pipeline. Pulmonary arterial hypertension, we also believe, is a disease of inflammation. And inflammation is an important target, potentially, for treating the disease. So there are new medications in the pipeline being studied that work on the inflammation pathway for pulmonary hypertension. We also believe that something called metabolism is abnormal in the blood vessel cell of patients with pulmonary hypertension. And folks here in Canada also are looking at drugs that actually target how the cell uses energy to try to help to treat and improve this disease as well. But we also know that in pulmonary arterial hypertension, cell growth is abnormal in the blood vessel. And you can get rapid and abnormal growth of the cell in the blood vessel, not unlike cancer. And so there are other treatments that are being looked at in different stages for pulmonary arterial hypertension, drugs that we would typically and potentially use in cancer. And they're being studied to help us to understand whether or not there's a role in pulmonary hypertension as well. And so maybe I'll stop here and I'll ask Dr. Mehta, Sanjay, what do you think about these new pathways? Do you think we're going to have a winner here?
Well, we certainly all hope so. I think the exciting thing is we have made a lot of progress, obviously, in treating pulmonary arterial hypertension over 20 years in the three pathways, as Lisa laid out nicely. We are concerned that we're kind of getting to a limit there. I don't think giving a new drug that's in the same pathway is going to achieve a lot more. I think what we've achieved in those three with the medications we have is close to the maximum. So it's going to take other pathways. And it's interesting in my mind, all those three pathways relate to things that are floating around in the blood of patients with pulmonary hypertension: endothelin, prostanoids, nitric oxide. And that was easy to measure, and that's been done for 30, 40 years. The next step is harder. It's in the cells that Lisa mentioned that are in the walls of the pulmonary arteries, the blood vessels that feed our lungs. What's wrong with those cells? Why are they growing? Why are they not dying properly? And why is there more of them? That's harder to target, understand first of all, and then find a medication. So I'm actually very hopeful that that's a very big direction going forward in terms of identifying why the pulmonary arteries are getting thicker and scarred and narrowed in patients with pulmonary hypertension. And Lisa might tell us a bit about our friends in Laval and Quebec City who are doing some fantastic work at identifying why those cells are not behaving normally.
Absolutely. Again, I will put a plug of gratitude for my colleagues in Canada and the work that they've done in helping to understand this disease. And at the bottom of the list there, you can read something called a PARP1 inhibitor, and it's very complicated and beyond my level of even expertise to give you great understanding on it. Suffice to say that there is a drug called olaparib, which has been used in cancer. And in fact, our colleagues, Dr. Sébastien Bonnet and Dr. Steve Provençay from Quebec City, from Laval, have recently been given funding from the Canadian Institute of Health Research to start to look at the efficacy and safety of this drug in patients with pulmonary arterial hypertension. So this is very exciting. This is a clinical trial that probably will start in the next 6 to 12 months in some centers across Canada, so that we can really be on the leading edge to see what the value is of some of these new pathways in our patients with PAH. Interestingly, and maybe it sounds a bit confusing, even though there are many cells and too many abnormal cells growing in the blood vessels of patients with pulmonary arterial hypertension, we also know that there's cell loss. And in fact, if you think of the innermost lining of the blood vessel, we believe that those cells are really important. And we also believe that those cells actually become damaged and die out in pulmonary arterial hypertension. And that may be some of the most earliest changes in the development of this disease. And so it gives me great pleasure to introduce Dr. Stewart, who you already love and know well, because Dr. Stewart he's leading this cause. Because the idea is, if these cells are abnormal, and if there's not enough of these cells to protect the blood vessel, then maybe, just maybe, we can grow new cells. And if we can grow new cells in the blood vessel, maybe, just maybe, we can prevent the downstream destruction of the blood vessel that occurs. So I'm going to pass it over. Duncan, what do you think? Tell us about this exciting news.
Yeah, so I think, first of all, it shouldn't be that surprising that we see both cell damage and loss and abnormal cell growth. I think these things are related. So whenever you have a chronic injury, then you have a response to that. Very often that's an attempt to heal. And this can be dysregulated, can not work well, and you get an accumulation of too many cells. So I think these things are interrelated. And so I've always tried to understand what is at the root cause of it. What is the first thing that's happening? What is driving the process? And that's very hard to do, because obviously when we see our patients, we believe that the disease is already fairly far along in its course. So it's very hard to try to get information about what actually happened at the beginning. And we have models and sort of animal models of the disease, but none of them are perfect, and we don't know how well they actually reflect the true disease. But based on sort of a lot of work done by many folks, including some from my lab, it's clear that the injury to this inner lining of these small blood vessels appears to be the key trigger that starts everything else going. So I think there's a lot of fair agreement on that. The question is, what kind of strategies can we bring to intervene? And certainly, I think the work being done in Laval, which is leading, I think, some very exciting programs that are moving into the clinic to try to attack that abnormal cell growth, is very exciting. But I think there's also room to look at how can we reduce the injury or repair better those small blood vessels that are getting injured and clearly are at the center of this problem. So for many years now, and so over 2 decades actually, that we've been doing this work, we've been trying to perfect a way that we can actually repair little blood vessels and even regenerate these small blood vessels in the lung. And like many things, you can do it in rats. If anyone has a rat with pulmonary hypertension, I'd be happy to offer you a very good therapy. But humans are another thing. So, but I'm very excited. The only way we can really know is by doing a well-designed clinical trial, to do a rigorous, well-designed trial, randomized, blinded, done in a multi-center way, and then really look at that in a very detailed way and learn whether or not that's working or not working. So I'm very excited that we've started this trial, and we have initiated 3 sites across Canada. As of next week, it'll be 4 sites, and we're hoping by the end of the year we'll have 5 sites up and running across Canada. This is not an easy trial, and not every patient would be eligible, but I hope that this will give us a lot of information, and hopefully will give us some hints that this may be an approach that could have merit.
So this is hot off the press. We have talked about new ways of using the same pathways with new drugs. We've talked about understanding new pathways and potentially new drugs that target those new pathways. And there's also something else that we've evolved to understanding in a little greater detail over the last year in pulmonary arterial hypertension. And that's the concept of more assessing our patient's risk. Now, you may look at us and you may say, well, isn't that your job? You should be doing that. And we do that. Every time you come to see us, at every visit, with every discussion we have, with every blood test and every other test that we subject you guys to, we're assessing your risk. But one of the nice things that we've learned and perhaps formalized more in the last year is that we can do this in a way that helps us to understand how patients are doing. We can look at how well you're feeling. We can look at how your exercise capacity is, and a number of different variables. And one of the things we've learned, and this I think is the sobering part, is that when patients come to see us in clinic, the first time they come to see us, very few of our patients are what we would consider low risk. And that's because our patients are coming to us too late. And that's some of the work we talked about earlier today. Getting patients to our door earlier makes a huge difference. But this is also sobering. Even after patients see us, after the first assessment, after they've started on treatment, up to 30% of patients only have one or no low-risk feature, which means that the majority of our patients are still not doing as well as we want them to do. And so because of this, we're starting to think a little differently about how we treat our patients with pulmonary hypertension. We're starting to think that maybe we need to use more of these drugs earlier on. Maybe that's some of when you may have had these discussions with your healthcare provider about maybe I should use a second drug, or maybe it's time for a third drug. Maybe it's time to think about prostacyclin. It's because we're starting to more and more understand the value of very, very aggressive goal-directed treatment for our patients. And we think that this is also something that's going to continue in the next few years. And so sometimes I think we all feel like this as healthcare providers that treat pulmonary hypertension. There's this gap between where our patients are and where we want them to be. And I think that part of what's so exciting and why I'm so excited about being here and talking about this today is that so much has changed in just a short time. New drugs, new ways of using the same drugs, and new pathways that might help us to understand the disease even more and stimulate us for even more new therapy to treat the disease and hopefully reverse and ultimately cure the disease. And so I'll open it up to my panel again, and maybe I'll ask you folks, what do you think needs to happen in the next 5 years in the field of pulmonary arterial hypertension? What's going to be the most important next step for us to close that gap for our patients?
Maybe I'll start. I think what's happened, and I've been at this game for longer than I care to admit, since the very beginning, the first inklings in terms of the pathways that Lisa showed and that led to the therapies that we have now. But I think we've got now a tremendous amount of information, more than we've ever had, but we don't understand it very well yet. So in the next 5 years, my hope is that we'll figure it out. You know, this conundrum between too many cells and too few cells. I hope in 5 years we'll have that figured out. We'll know exactly why that is and where the opportunities are to intervene to prevent this from progressing and to improve the disease. So right now, you know, we're not sure. You have to have an idea, hypothesis, and test it, and ultimately it's got to, you know, we have to understand in our patients what works and what doesn't work. But in 5 years, if we have a much better understanding of these complicated mechanisms, I think it'll focus our attentions really on the direction where we're going to get the most impact in terms of therapies.
I see a time within 5 years from now that I have a better sense of when a person comes to see me why they have pulmonary hypertension. Not the fact that it's idiopathic or scleroderma or CTEP, but more than that, what makes their pulmonary hypertension different from somebody else? And so you know the three pathways, we've talked about them. Right now I don't know which of those drugs is most important to you getting better. So I often give you all three, at least two often. I think in the future we're going to have a better sense of what we call precision medicine. So I'm going to be able to tell in you this pathway, be it endothelin antagonists or prostanoids, is more likely to work better. That's what we should focus on. So I think it's going to allow us to use less medications in many patients, maybe have less side effects, and then also obviously treat you better without having to add 3 medications with the cost that it takes. So that's what I kind of see. So the idea of precision medicine, knowing better how to treat you.
Yeah, I mean, I think both Sanjay and Duncan mentioned the same sort of thing, which we also call sort of personalized medicine. But the idea of trying to be able to, the way we categorize pulmonary hypertension now is still very broad, and we know that it's not as simple as we draw it out on a piece of paper. To be able to understand the different populations better and understand exactly what type of medications will speak to an individual's disease would be a huge step forward. I think in the next 5 years, as we've gone through the last 20 years of growth, and there's been an explosion in the use of in the types of medications we have, you know, I think it's also time that we start turning towards many of the aspects of patient care as not necessarily just medications. As we're more settled with the medications we're using, maybe we can turn some of our energy towards many of the aspects of taking care of patients that it's not necessarily just writing a prescription. Be that their overall wellness, the caregiver support that has been discussed in the clinic, as well as support with medications and then the financial and the social burden and everything else that goes along with having the disease. And the third part, I guess, is, again, outside of just medications is, and this has also been, I think, one of the themes and topics of discussion around the tables today, is the earlier recognition of disease in patients and diagnosis. And that may come with precision medicine if we can identify people that are more likely to be predisposed to developing pulmonary hypertension. Maybe we can catch the disease earlier and intervene earlier, or with different genetics to understand who should be targeted sooner, and who we should worry about more and who can worry about less.
Very exciting, and I think we're going to get there. I really do. I think the work that's being done, the research work, the advocacy work, all the things that are being done internationally, but especially here in Canada, I think will help lead the way. I'd like, if possible, to open it up now. This is your chance.